Thank you, Tony. So Tony's going to talk about the corpectomies, and you want to basically complement Lee's talk.
Yeah, so this is going to be a worse talk than hers. So she did an amazing job, kind of explaining the anatomy and so forth. So, this is actually an orthopedic surgeon who fell out of a deer stand, went to his office and basically had this. So burst fracture, this is the MRI. And so, traditionally, this is, again, a high-functioning guy, orthopedic surgeon, and, kind of wanted the least amount done. And so, traditionally, we would do everything posterior, 2 up, 2 down. And this is something where, and even though this is Mark 2, it's actually L1. But it's something where, this was a TLX 5, I believe, too, as far as scoring goes. But, he wanted kind of the least amount possible. So he came and saw me, and really kind of the goals are really the same. So we want to decompress the neural elements, stabilize the anterior column, restore coronal and sagittal alignment, and then again, provide adequate fixation. So when we talk about corpectomies, there's kind of lots of indications. I won't go over all of them, but trauma, infection, tumor, deformity. And so, these are, certainly cases where, doing corpectomies, having that anterior column support, kind of goes in line with the reasons why we do ALOS and laterals. Traditionally, we've done these big whacks. So we have these, big incisions. If we're trying to do it posteriorly, typically we're doing these wide, large dissections. We're working around the cord, doing these kind of big VCRs, taking the nerve roots, kind of rolling the cord and the dura over. It's a technically challenging operation. Definitely the pucker factor's there, just kind of working around the spine. And so, the advantage is it's familiar. It's posterior. We're all kind of familiar with the anatomy, but it's one that these are big surgeries. And certainly open thoracotomies, the typical shark bites. Again, large incision. Typically, you have to deflate a lung. Like Kwon said and Liz, is that a lot of times these thoracic guys are just throwing in chest tubes left and right just because that's what they do. And again, I think one of the advantages that you have another surgeon there, they kind of show you the world, and you just kind of do your orthopedic or neurosurgical procedure. And so, obviously different approaches. I'll kind of go a little bit quickly over this. And so, now the idea is that we can really do this wide decompression from a lateral approach. And so, for me, one of the biggest kind of eye-openers were actually doing thoracic discs, where we could really kind of take down the pedicle, get into the canal above and below, and you can kind of see and you can feel all the way with the pen feel all the way down the vertebral body, so you know that you've decompressed the spinal cord and the spinal canal. Doing it from a posterior approach, you just never really were sure. In fact, one of my old mentors used to have a little dental tool that he would put in with a little mirror to kind of see if you fully decompressed. So it's one where, again, I think that for me was a great case because I was 100% convinced that I decompressed the cord. We talked about these kind of considerations. So I do the same thing for my transthoracic, is that I'll typically do a red rubber catheter, and I'll put a little whip stitch around the intercostals, and I'll basically put it to water seal, and it's kind of back to your general surgery days. Basically, if you violated the visceral pleura, the bubbles keep on coming. So you put it to water seal, you see some bubbles, and they just don't stop. If you get in that situation, then they do need a chest tube because the visceral pleura was violated. If you kind of put it in, you see 1 or 2 bubbles, anesthesia gives a deep breath, the bubbles kind of stop, you know that you haven't violated the visceral pleura, you just kind of pull it, tie it, and then you're done. Again, I don't typically get post-op chest x-rays anymore. They always show a little apical pneumo, but there really is kind of nothing to do. And so the advantage of the retropleural approach is that, again, I think that you as a orthopedic or spine surgeon, neurosurgeon can do this. I typically take down the rib. I'm not as talented as Dr. Lord, and so for me, it's just easy to take down the rib. I can go retropleural, kind of deflect the diaphragm if I'm by the TL junction, or if I'm higher up in the thoracic spine, really kind of stay retropleural. And really with the current retractor systems, light sources, the first couple I did have a thoracic surgeon there with me, just kind of really to make sure I wasn't doing anything bad, and it was a unfamiliar approach. But after a while, he was telling me that this is a better approach than what he could do, because he's typically using your typical retractors. These are kind of tailor-made for this approach. And so, really when we talk about access options, really kind of transthoracic. Again, you can be retropleural, but you're kind of transthoracic. Really kind of T4 might be a little high. I think the highest I've done is about T6. Once you start to get above that, the axilla, shoulders kind of get in the way, and it's just really, really hard to see. TL junction, which is the vast majority of work, there's different ways depending on where the diaphragm is, where things are located. You could be transthoracic, you can be retropleural, you could be transdiaphragmatic, retroperitoneal, you could be retrodiaphragmatic, retropleural. And so kind of at that junction, and hopefully we can maybe do this in the lab, really kind of that 11th rib is kind of the gateway to that area. And so really for T12L1, again, I'd say sometimes it's one of those three, but it really kind of just depends. And then lumbar, typically it's retroperitoneal. I typically won't do an L4 corpectomy, just because I feel like I'm spending too much time in the SOA, so I'm not as brave as some of the other guys here, but I'd say L3 is probably as low as I'll go for a true corpectomy. So, steps, I don't want to kind of belabor what Liz did a great job showing, but I'll kind of mark out the effective vertebral body, mark out the rib, and really I want to identify that traversing rib. Again, I always take the rib for corpectomy, just because I feel like it makes my life easier. And so managing the neurovascular bundle, really the rib resection, a couple things. One is you want to make your skin incision a lot more posterior than you think. So I'd say it's about maybe 3 centimeters behind the back of the vertebral body. I'll typically use like the little Alexanders, which again kind of get subperiosteal. And then the other end of the Alexander kind of really can get underneath the rib. And I really spend a lot of time defining the upper and lower borders. If you go right to the pigtail, you'll just go right through, the pleura. And so really kind of spend that time to make sure that plane is really dissected. I'll even sometimes get a Cobb elevator, and I'll go from superior to inferior, kind of, again, making sure that I'm really hugging that rib. Once I've done that and I've really detached the pleura, then I'll put the little pigtail in, go up and down, and you really want to get way more rib posterior than you think. And even though I'll kind of say that and I'll know it, inevitably I'll do it, and then I'll have to take more rib a second time. So just take a lot more rib than you think. Typically, I'd say it's about 4 centimeters of rib that I'll take. It's great bone graft, so I typically will shove it in the cage, much to our biologics' dismay. But typically, the rib is great bone graft. So when we talk about the retropleural access, I really use the retractor to my advantage. So if I'm using, let's say, a typical 3-blade retractor, I'll kind of have the posterior blade right at the posterior border and that fan right at the anterior border, and that way I kind of know where my margins are, and I know that I can just be inside of those and be safe. If I'm doing something that's in the canal, burst fracture, thoracic disc, I'll actually make the posterior blade 10 millimeters shorter so I can account for that upslope of the rib head as well as the rib. And so, one of the things that I've also kind of done is, especially if I'm doing lumbar corpectomies, is I'll do discectomy, like kind of you're doing a lateral. I'll move the retractor, dilate over the next disc space, do another discectomy, do the box cutter, and do a full discectomy. And really do that, and then I'll kind of move the retractor a third time to kind of put in the middle and then kind of connect the uprights. The reason why I do that is really 2 things. One is it gives you some parameters, like a little goalpost to know where to aim for. So if you have your 2, kind of box cutter marks, you just have to line everything up in between and you're going to be safe. It allows you to also find your orthogonality if you've kind of got those 2 kind of channel discectomies that you've done. The other is that it's always that far disc that keeps you from getting that implant far enough across. And so again, I think people get a little bit rushed with the corpectomy part that you don't do a very good discectomy. So I want to do a great discectomy on both sides, just like I would do for a lateral interbody spacer, and then again, kind of connecting the dots. So, again, taking down the rib, kind of this retropleural, I don't know if this video is going to play, but basically once you kind of incise the rib, you just kind of follow that rib down with your finger. And so it's kind of like cobwebs, but you're kind of sweeping the rib. Will it play? Oh. It's not working. That's okay. Well, it kind of feels like cobwebs. So you kind of are like gently reflecting the pleura, kind of one rib above, one rib below, and you're kind of going until you run out of finger. And then I'll use like the endoscopic Hittners and keep on going to that P to A approach, kind of following the rib down, and then I go to the vertebral body. Once I'm kind of down there, I'll get like a sponge stick, and I forget, I think they're either called, the OBs use them, but they're like these little like cottonoid balls that are really kind of tight and small, and they kind of serve as sponge sticks, and I'll kind of just use it to kind of keep on sweeping the pleura anteriorly. And then once I have my dilators in, I'll kind of do that same P to A motion, get it where I want, put the dilators, put the retractor, and then again, I'm kind of aligning my blades across the disc space as well as anterior to posterior. Being an orthopod, I use osteotomes, and so I think they're quick, they're easy. Same issue, I found that I tried the burr, but it just takes too long, and we don't have the long attachments to get that far in. So the osteotomes are kind of the workhorse. I will do this under fluoroscopy, so I use the same benchmarks that Liz uses, and so that medial border of that pedicle is pretty much where I'm going to. And then they have these kind of big rongeurs that you can kind of grab the bone. So, this was kind of the final result. So we did a lateral interbody cage with interfixated screws and then percutaneous screws in the back. But it's a case that, we did in about 98 minutes in terms of OR time. We lost about 50 cc's of blood. And, he went back, to work really in 2 weeks was seeing patients and 4 weeks before he was doing surgery. And it's just one that I think when you look at the post-op course of their kind of traditional ways that we used to do it versus the way we've done it this way, it really has been kind of a game changer. Looking at kind of studies, I'll pull one of Juan's that he did with Bill Smith, but looking at mini lateral approaches for the thoracic lumbar spine for burst fractures. Again, high success rates. Of note, this was a combination of the cylindrical interbody versus the one with like the end caps that kind of mimic lateral interbody spacers, but the ones that kind of had the apophyseal ring spanning implants had zero subsidence. So that's been kind of my end plate of choice. So basically in conclusion, we can do it safely. I think that the fact that you don't have to have another surgeon there is critical. I never use double lumen intubation. It's always single tube. I can keep both lungs inflated. And again, we don't need a chest tube. Gives you direct access. And for me, that was the biggest thing is I felt 100% confident that I did a good decompression because I can see all the way down. And really the other thing is just kind of saving level. So when you have a big interbody spacer, you have a good anterior column support, you don't have to kind of go the traditional 2 up, 2 down. So any questions regarding that corpectomy?
You have your posterior fixation first?
So I do not. So I always typically will do my corpectomy first, mainly because I feel like I don't want to be kind of tethered posteriorly. So if they're kind of have post-traumatic kyphosis or if they're really kind of collapsed, I want to be able to use the power of the expandable interbody spacer. So I'll always do my interbody first. Question?
One of the challenges in the thoracic spine is when you come down, you encounter the rib head over the side of the spine, and it's so like firmly attached through the capsule. Do you have any tricks for getting that off easily to get access?
Yeah, so I'll typically use the they call them osteophyte biters, but they're the aggressive pituitaries to try to like remove the bone. And then that is probably the one time I do try to use the burr because it is a little more superficial to try to get it off. Once you get above T12, that rib is just right there. And so, I've tried osteotomes as well, but I would say that osteophyte biter has probably been the saving instrument that I use. Any other questions? So the other thing I will say for thoracic discs is that, when I've done them, really kind of the key is doing your discectomy first, but I kind of do the little corner, little osteotomes in the corner to then kind of pull the calcified disc and the bone all as one chunk. But you'll find that you'll take that calcified disc, it's, firmly attached to like the bone. And so it's very difficult to just, move a disc, into the disc space. They tend not to be very soft. But that's something that, again, has been, made the thoracic discs very easy.
On your construct where you have the screws going through the cage, was that for fixation or is that just for migration purposes that you did that?
Yeah, so I just did it for anti-migration, to be honest. It wasn't for fixation. Again, he was, 48 and healthy, so I think I probably didn't have to use it. But it was one where, because he was an orthopedic surgeon and was going to look at these x-rays every time we did it, I just felt like that was kind of the, right thing to do. But I'd say most of the corpectomy cages are probably not, I'm not using this for.
So I do want to commend you on your work for burst fractures. For me, as somebody who worked at Harborview for 25 years, the advent of XLIFs with competent practitioners like yourself and my partner, Dr. O, has changed the game. I mean, short segment fixation was poo-pooed until that came along. The insight that by abutting the apophyseal end ring through the extra large transverse component of the cages is a very welcome and necessary offloading mechanism. Still not sure about the posterior percutaneous aspect, but that's to be debated. But I just want to recognize that are there considerations, like what I'm seeing on that lateral is that there's still disc there. So are there considerations of how to optimize the discectomy part so you have a true end plate purchase? And when you have these extremely concave end plates, is there a trick that you use to kind of get a better fit?
Yeah, that's a great question. So if you look on the AP, it's, there definitely is kind of a dome component. So you're right, it sits on that apophyseal ring and you'll see that kind of gap. And, there's always a saying that titanium never lies. And so for this, I'm probably relying on that anterior column support, but I am just packing bone, so I'll pack bone around it. The little cylinder has bone graft that's in it, so I'm probably using more of a biologic to assume that that's where the fusion's going to occur. But you're right. I mean, there's certainly domed implants that they make now, so it kind of matches that concavity. But it is something where it's always going to be a little bit of a challenge.
One more follow-up question. So, again, I have the blessing of an extremely facile partner with Dr. Oskuian, but can you confidently do a full corpectomy and a neural canal decompression, a high-grade burst fracture from anteriorly, or is that something that should be done posteriorly as a first stage and then supplemented anteriorly?
It's about surgeons. I'm telling you. You're killing us right now because I've been criticizing so much when sometimes industry and people send me like pictures like, oh, wow, watch this doctor, whatever, did a corpectomy and they show the cage and the screws and that, but you look at the images, the whole posterior cortex is intact. I said, this guy just make a hole in the vertebra, force a cage on it and walk away. The most difficult part of a corpectomy is actually the decompression of the neural elements, which is the whole reason to do it, So the point is, if you do a corpectomy and you don't spend the time taking the PLL and leaving the dura exposed, you just a liar and you just taking advantage of the system, Just do a posterior, go and get some spondylectomy, get some indirect decompression and ligamentotaxia and walk away. But you don't know how furious I get when this industry, sometimes they show me like, what this doctor, amazing corpectomy, first one in the nation, and things like that. And I look at life like, listen, this guy just make a hole in the middle of the vertebra, force a cage on it, and then put 3 percutaneous screws. That's crazy, no?
Yeah.
It's just,
yeah, I mean,
that's a great question, Chava. Hopefully people
Yeah.
get it. you
So
know?
I think, if you do the corpectomy part and you can kind of create that bony void anteriorly, then, they have these kind of curettes that you can essentially kind of, reverse angle that just kind of pull the bone into that void. So I think the first step is doing your anterior posterior cuts. You take the majority of the bone away, and then you can kind of flick, the fragments of bone.
Yeah,
And
exactly.
they just come right into
Sometimes
that
even
void.
pushing on the back of the patient when you're doing it lateral or even the prone, you make ligamentotaxis by doing that, and actually a fragment comes into the
Go
field.
to the disc, posteriorly to the disc first, until my curette can find the canal, and then start
Moving things forward.
grabbing the little piece of bone. As less bone we leave posterior, easier is the work to
Exactly.
decompress
Yeah,
the
so
canal.
usually with the burst fractures are typically on the superior portion of the bone.
That's
And so
what
like
felt
Luis
good.
said, so you go to the disc level, you go find your canal, and then you can kind of go below your fracture towards the bottom, find the canal. So you're like in the canal above and below, and then you start kind of pulling the disc in. But it's one where, it's challenging, but it works great.
Yeah,
All right. Do you have another
that's good.
time?
Thanks very much, Tony. It was a really good talk. So we have time for questions or commentaries. We're going so good with timing. Someone wants to throw a joke or something in here? Anyone has a good jokes? Something maybe? Neil, what about you? Anybody has a good joke in here? So we have some time. Corey, no, Nima, who's the good joke? You have a good jokes, Corey? No? Everybody's boring in here. No one has a good jokes? Anyone? Pimenta, Brazilian joke, something.
Oh, no. He's verboten.
Who's the All-American
Sorry,
in here?
I stole it, Neil.
Yeah, any comment? Liz?
I had a question actually for the audience. So at this point, in my hands, I'm doing a lot of prone lateral, but I'm not quite ready for a prone lateral corpectomy. I wanted to speak to those in the audience who are doing those, mostly how you safely anchor that retractor into the vertebral body so that you don't have the migration. Because when gravity is helping you, as I showed, it can, you're going straight down. But I worry about essentially migration of the retractor if you don't have that interdiscal shim because the discectomy has already been done.
Yeah, I mean, what you want to comment, Pimenta, Corey, you've done already one prone, yeah? You haven't done it? Who's done a prone corpectomy here?
Yeah,
McMills?
Well,
Yeah, I mean, that's in the works, Liz. There's very few cases, actually, and I'm telling you, one of those is when they send me like that. Amazing, first one in the world, prone, and I saw entire vertebra on the back. I say, guys, you're kidding me,
yeah, one thing that we learned early on is that when we have the patient in prone, the retropleural access is easier because of gravity. That is the first advantage. But you are right. The key thing is how you keep the retractor in the position. When I saw you doing corpectomy, I thought she has to learn with us the retractor that we have, because in the way to have a very strong position of the retractor and keeping the anatomy, which usually is disturbed by the pathology, is very, very important. We have a retractor that covers from disc to disc, from anterior to posterior as well. So has an amazing view, disc, vertebral body, and disc. So we are really doing everything under direct view.
So, Liz,
Under new Anand definition is not MIS procedure.
so Liz, I haven't done in
That
cadavers,
corpectomy is
trying
definitely
to-
not MIS. Thank you.
Yeah,
I
I've
don't
done
care
it
what
in
approach you
cadavers,
use.
trying to figure it out, and it works, but it doesn't look too complicated, to be honest. It's just you need to have a dedicated retractor for that. One of the problem with the retractor nowadays is, especially in prone, you have to be very careful that the retractor is holding it, because the gravity is not in the best help. When you have depression on lateral, at least you have something to push on it. Arms are getting better, but you have to keep probably babysitting all the time that. To be honest, I haven't done. And don't forget, corpectomies, we're doing less and less and less and less. It's like OC fusions, They're becoming like a dinosaurs. Yes, sir.
lateral fusions, whether it's OLIF or lateral, how do you choose a right-sided approach versus a left-sided approach, especially if there is fusion on the opposite side with the
Okay.
osteophytes? Do you still go through the osteophytes, although there's a narrower side?
Yeah. Yeah, that's a good question, and there's many ways to do it. I will tell you my my own bias. Obviously, someone has in here. Most of that I learned it from Pimenta, Taylor, or Barney at the beginning, I remember. So my own bias is always attack. If I can, I attack the osteophytes up front. I prefer to get it up front than do it on the other side, Seems and looks like more difficult when you go through trying to dock the retractor on the osteophyte, but you get rid of that right away. The other way is right or left, to be honest, to me, is the first thing that I look is the shape of the psoas and where the vessels are located, Once I clean that part, where I have the most favored psoas, I will say when you see that the plexus is posterior, I don't see any vessel in my way and this and that, then for example, right or left in 4-5, I prefer to go on the side where the vessel is closer to the approach than running away from that, because the problem is the contralateral release. Neil doesn't do it, but most of us, we do contralateral release. If you're not totally perpendicular, you hit the vessel right there. So you do the approach from that side. Actually, when you put the retractor, you know that the vessel is already retracted. So at the other side is nothing. So that's why you say, if I was telling this morning that we were looking at our cases, my own cases, which ones are more right or left. Actually, I've done more right than left. The other thing that I look is at the iliac crest. Usually you're trying to err where the iliac crest is lower, But it has to have a good psoas. So the first thing to me is the vessels, the psoas, the crest, and then in the deformity, I always try to go concave. And I'm gonna tell you the 3 or 4 reasons concave. When I put the patient on lateral, when I break the table in concave, you start reducing the deformity right away, yeah? Because if you start from the concave by breaking the table, you're trying to straighten it up, yeah? Second one is one incision, it can take me to a couple of levels right away. When you're on the convex side, you end up on L1 in here, on L5 in here, it's become like these huge incisions, like you're over the place. So that's what I like the concave. But the concave also has a downside, because normally the vessels migrate to the concave side, and the structure. So you need to know when, what you're dealing with. You ask Neil will say, I always go from the convex side, on the formulas. And you always go on the convex side, correct?
No, always on the left side.
Okay,
My
left
approach
side.
is completely
Okay,
different.
so he doesn't mark convex.
You can't equate it.
Left side because you.
Because he do pre-psoas, because he's pre-psoas, yeah.
You have to go left side if you're pre-psoas.
Yeah, your pre-psoas have to be,
It's because of the anatomy of this.
No, I want to be next to the aorta, never on the IVC side. That's it.
Yeah.
So it doesn't matter, concave, convex, it doesn't matter.
I don't-
Looking at the psoas, it's an anatomical approach. It's an ACDF of the lumbar spine.
And
You
there
see
is,
it.
yeah, and there is one more thing. If you are doing lateral surgery, you're a lateral surgeons, and you guys have seen the iliolumbar vein someday, you're not doing an MIS. You're doing something big, because normally, the iliolumbar vein lives in 4-5, and open surgeons, when they do an A-lift for you, the first thing that they're doing is trying to find that freaking vein and get rid of it, and so they can go to 4-5. To be honest, I never seen the lumbar vein in my life doing a lateral surgery. I never seen it. Never. You tell
shouldn't
me
see,
why.
Unless
It's very
you aren't
interesting,
sure.
no?
Neil knows probably better.
No, we never see it. Never. I've never
It's
seen it
interesting,
ever.
yeah?
No, but what I've said this many times. For me, it's studying the MRI before I start. If you study the MRI, you got your access. MRI is everything for me for access. Whether I'm doing A-lift or whether I'm going lateral. It's all based on the bifurcation. I don't care what the services, where the crest is. I've said this many, many times. Embryologically, the bifurcation is directly correlates with the psoas and the iliac crest.
Yeah.
They're all segmentally developed the same way. In other words, if it's a high bifurcation, it is segmented out. It's a high psoas, it's a high crest.
Yeah.
It's a low bifurcation, it's a low psoas, it's a low crest. They go together.
Yeah, and the other
That's
thing
all you got to
is,
see.
Yeah, that's a good point. The other thing is when you're dealing with a high crest and you work with the retractor angles, you're like an angle instruments and that. There is one thing that you have to keep this one in your mind. You remember this one, you will appreciate what I'm saying. Every time you work in angle, you always go anterior. Somehow it drives you anterior. So when you work angle, make sure that you're not biasing too much anterior because you end up damaging the ALL and ACRs and inadvertent ACR, you can get vessels injury. So every time you're doing, I don't know why, but it always happened to me. I don't know if you guys had the same experience. Yeah?
Yeah, I think a lot of it's because, and I've seen it as well, but it's because of the traditional retractor, the caudal blade, because it's sitting on the crest, even at an angle, your hand has to slip on either side of it. Okay. And so, the tendencies, if you're behind the patient, is you want to look in the field, so you tend to slip your hand more posterior, so it goes more anterior. That's the one thing about the split blade retractor is that because there's not a caudal blade, you have less of that issue with that kind of design. So that's been my preference for 4 or 5 is having the split blade. But I have seen with our residents and so forth that because of that caudal blade is right on the crest, again, the tendency is to slip on either side of that caudal blade.
Yeah, and one more thing, Corey, before you go there, is also this surgery needs a lot of common sense. I always, when put the retractor, I always look for the slope because I don't care what the X-ray show you, what navigation show you. If you see a slope, you know that that's the ALL. That's your anterior limit, If you start working on the disc more, on that slope, I promise you're going to damage the ALL. And you're going to end up with cages that hold the cages with the screws because it's going to migrate. You're going to end up dealing with So always make sure that you work in the flat part of the vertebra. You don't want to work on the slope.
So one of the things I've learned and I think is an easy mistake is when you're trying to put your initial dilators in, everybody wants to be orthogonal to the disc space at 4-5 or at the top, and you end up pushing against either the ribs or the crest. And what'll end up happening is it just pushes the tip of the retractor higher or lower depending on what it wants to do. So the best thing you can do is don't worry about being perfectly orthogonal until you get your shims into the disc space. Work on that angle. Once you have your shims docked into the disc space, then you can bring the retractor up and it's docked in the right place. If you try to do it too soon, the bottom just pushes out.
That's also the Wimpel wide shield maneuver, like the butter on the knife on the butter, If you're angled with the retractor and you start trying to move it, normalize it, if you don't have a shim, the retractor goes like this. By the time that you get there, you're actually half on the vertebra up, That's a good point. So put the shim, and then once the shim is there, you can start cranking the ribs up or the iliac crest down, I notice it with the prone lateral, I'm dealing lately more with the crest and the ribs, because the nature, So all these things are good trips.
The prone lateral procedure with the 2-blade retractor, what we have been doing recently is using 2 shims. I saw in your case you struggling a little bit to place the shim, probably because you use 1 shim. If you use 2 shims, the 2 shims anchorage to the disc brings your retractor to the best position possible.
Yeah. But you use 2 shims, Corey. You're basically using 2 shims.
I use 2 shims.
And the orientals.
Yeah, because if you just have the back end, and when you go to turn it, it'll actually lose the angle of the disc space, and then you go to expand.
With the 2 shims, there is a trick also. 2 shims are great, but you need to make sure that you're totally parallel to the end plates. If the retractor is a little bit like this, one of the shims is going to end up awkward. So make sure that you take an X-ray on that's the problem when we migrate into navigation. All these things is going to be tough because we don't see them.
I got a question actually for you, Neil, or anybody else that's an anterior psoas guy. When you have that like Mickey Mouse psoas appearance, the transitional anatomy, and not just really the fact that the psoas and the plexus is drifting anterior, but the vessels have turned into the 4 commons, and they're starting to kind of sneak around the corners.
Your case, I'm all right.
Yeah. So what's your thought process, and what are your considerations as you're docking, and then as you work across the disc space, that far-sided vascularity? Like how do you deal with that from an anterior to psoas standpoint?
So when you look at the first, as I said, bifurcation.
Fighting or we're okay?
No, you pull up an MRI. It's a beautiful MRI. Actually,
So we're
describe
not
it.
fighting, okay? Because if we're fighting, I don't show it.
Fighting. There's no fighting. No, I was going to explain to him.
What is that?
So
Transitional.
Where everybody's talking about transhose, I want to hear about.
Yeah, I'm gonna put it in here.
No, it's okay. It's okay. They'll never learn it. It's all right.
I don't mean it as a fight.
No, they'll never learn it. It's okay.
Do we have
So
it?
if you look at the vascularity now, that was bifurcated, right? It's X-ray. It had already
see it in a
bifurcated.
second.
The aorta always bifurcates before the IVC by about a centimeter. That's anatomy. Aorta will bifurcate before the IVC. The IVC is always below. The left internal iliac, always left side. I don't care the right side. Left internal iliac is always below the left internal iliac artery. Now, if you follow that, see the aorta is bifurcated way more. Do we have a pointer? You can see everything there. It's actually beautiful anatomy. No, something.
Which one you want? This one,
No, let me-
this one, or this one? All of them are bad.
All of them. No, they're great. None of them are bad. That started bifurcating there, right? That's probably
Just use the
there.
pointer.
That's lower down, right?
Use the mouse.
This
Use
is
the mouse.
this is the level.
Yeah,
No, I
use
got it.
the-
No, I got it.
use
Hold
the
on.
mouse.
I'll show
You don't know
you.
how to use a computer. What's wrong?
This is the level you want right there, right? This is right at your disc level. If you go one level down, I always look one level down.
There, yeah.
It's still good. Why is that good? I'm going to go back here. Look here. The aorta is split, right? It's split. That's aorta. That's your IVC. It is still lying right of the aorta, which means I can still safely go down this plane. I'm not going to encounter the
What is the
left
ureter there?
internal iliac vein. Now,
What
go
is
what?
the ureter?
You know, ureter is never here. It goes with the peritoneum. The ureter goes, if you swept your peritoneum normally, it's not there. You cannot see it. If you tell me you can see it, that's a total fake. The guys come back on and on. Those are small little things you see on the peritoneum, on the fat. They're vessels in the peritoneal fat. Those black dots, I want all sorts of crap. They're not. They're all vessels in the peritoneal fat, and they go away. When you sweep everything off, the next thing for me is on the direct vision. I'm looking at the anterior border of the psoas and the disc. But anyway, back before all that, in planning, right, go one more step down. That's one more step down. It's still okay. This is what you want to watch. This guy will sneak below and out. You want to watch one cut below. That's about as much as you're going to open your retractor. Like Juan said, there is no reason to open anymore. You shouldn't be. You should be opening just that much to look at it. You're still okay here because the IVC is not snuck underneath the aorta. That's what I watch for. If the IVC of the left internal iliac has snuck underneath the left internal iliac artery, you're going to get it. Because think about it, your probe is coming, even under direct vision, it's coming straight down there. Okay, and I did not by any chance want to get the corner of that vein. So as long as you're there, I can feel the aorta. It's like an ACDF. Literally like you feel the carotid. With your finger, you can feel the aorta. It's right there. And all you'll end up doing is this. Secondly, this also moves. As you sweep it, it moves. It's all an areolar tissue. I would say this forever. We don't measure the distance of the carotid from the trachea and esophagus. We do ACDF every day. How the hell did we learn to do a Smith-Robinson approach? We're so terrified of this crap. Maybe Jens can teach us. How did they teach all of us a Smith-Robinson cervical approach? I would love to meet those guys. I would love to. We should have talked so much about this. This is 5 times bigger than the ACDF we do every day. And we put our finger down, go right past the carotid, trachea, esophagus, right onto the vertebral plane and do
I
it.
will take a jugular.
How did they teach us?
That an IBC anytime.
So what I'm saying, no, we're not going IVC. So the aorta is what you want, right? You want the aorta on your side always. So anyway, that's the plan. So if it had already bifurcated and the internal iliac was already out, I wouldn't do it. That's an ALIF for me. As long as it's on the inside, you can still do a lateral. That's all. And then the psoas moves. The psoas moves by itself. You don't have to do anything about it. It moves.
Okay, so we're gonna keep moving, guys.
Thank you.
Well, we're gonna have Dr. Pimenta. Are you there, Dr. Pimenta?